All right, so this morning we are going to talk about two different applications in clinical lab testing: drugs of abuse testing, DAT, and therapeutic drug monitoring. So they serve two different purposes, but they're each equally important. We actually, as employees of the government, participate in one of these every year, sometimes every month. We'll talk about that a little bit later on. But in terms of their utility, drugs of abuse testing is simply to determine whether or not a drug, illicit or used for unintended purposes, has been used in a patient. So we're looking for detection of a drug, yes or no, above a cutoff limit. Then for therapeutic drug monitoring, we are measuring the blood concentration of drugs with intrinsic properties. The drug has intrinsic properties that make it kind of variable in terms of the drug's pharmacokinetics and or pharmacodynamics. And we're going to talk about examples of each of these and how they tie back into the general principles of pharmacology that you guys are very much familiar with. Right, so here is a clinical scenario that I wanted to start with. We have a 45-year-old male with a history of epilepsy, presents with slurred speech, nystagmus, and confusion. His wife reports he recently restarted phenytoin, but has missed some doses. A stat blood sample was drawn on this patient, showing phenytoin levels well above the therapeutic range. Also, this person was given a UDS, urine drug screen, and that results show positive for marijuana, raising concerns about compliance and medication, potential medication interaction. So this patient's phenytoin dose was adjusted and he was counseled in terms of substance abuse. So starting out with this clinical scenario, have you guys talked about toxidrome yet? Toxidrome? So toxidrome is the kind of clinical fingerprint on how a patient presents based on properties of the drug, based on the drug's mechanism of action. So phenytoin, I'm just gonna give phenytoin bottom line up front. Its toxicity presents with slurred speech, nystagmus, and confusion. That is because of its interactions with the cerebellum and the vestibular system. Also, ataxia is seen in some patients. So, have you guys done anticonvulsants in pharma already? So, tell me some things about phenytoin that you know.
Not the first one.
One person, because I'm hearing a whole bunch of stuff. Somebody said congenital adrenal hyperplasia. I don't think so. No, not that. Right? Is that used for that? Gingival, sorry, gums. I can't hear. Yes, highly protein bound. That's what I wanted. That's one of the answers I wanted. Thank you very much. Phenytoin is highly protein bound. What else do we know about general properties of the drug?
Sip stuff.
CYP, okay, yes, CYP. What is this drug metabolized by?
3A4.
Well, everything is metabolized by 3A4. That's correct, but what else?
600, Bob.
600 BOP?
That was the prices were, sorry.
Oh. Phenytoin is metabolized by 2C9 and 2C19, also 3A4. One more thing that I want to get from somebody about properties of phenytoin that make it very important when you're prescribing it to a patient. Stevens-Johnson syndrome? Just the general properties.
Narrow therapeutic
Narrow therapeutic index. Right? Yes? No? Man, you guys were happy to see me. Now you're treating me like I'm teaching biochemistry up here. So it's okay. So phenytoin is highly protein bound. It has a narrow therapeutic index. And what does that mean?
More moderate. It's a moderate one.
Yes, why? Correct, you're correct. Why?
Because you have a very narrow range for where it may be more toxic.
Correct. So yeah, so drugs with narrow therapeutic indices, there's a very small range from where a dose given can be efficacious versus toxic. So phenytoin, highly protein bound, narrow therapeutic index. What do we know about marijuana? How is it, or THC, how is it metabolized? What enzymes? 2C9 and 2C19, I'll just give them to you. The same enzymes that break down phenytoin. So in this case, there could be some competition for enzyme metabolism. Also, one thing about phenytoin that I'm not sure was mentioned, it is it follows zero order kinetics. And what does that mean? Constant amount is broken down per given time. So phenytoin is like the poster child for a lot of considerations when prescribing. So that means that it is going to take a long time to be metabolized, especially once it gets into the toxic levels, because I don't know if you guys remember the analogy I gave last semester. All Walmart lines open, that's first order. One line, which is really what we see, is zero order. So the drug just has to wait in queue in order to be metabolized. But now you add in the same enzyme metabolizing THC and phenytoin. These are reasons why you guys need to know as much information that you can about a patient when you are prescribing a drug. So, but getting back to this clinical scenario in general, so the patient presents with clinical signature characteristics, that's the toxidrome, that all affect the central nervous system. So these symptoms indicate that the likely effects or clinical presentation of this patient are probably primarily due to a toxic level of phenytoin in the blood. And so that's why TDM is used to adjust that down so the drug could be, the drug dose that will be given to the patient will be in a therapeutic range in the blood. Are there any questions about this scenario? All right. So in terms of clinical lab testing, there are 4 general areas of toxicology. We talked about the last one, toxic detection, when we talked about those agents that have anecdotes or those agents that are seen in the ER or for clinical management. That's what toxic detection is. Environmental toxins are toxins found in food, water, and air, and they potentially cause cancer. Those agents or compounds are also tested in clinical lab. And then this morning, we're gonna talk about drugs of abuse testing and therapeutic drug monitoring. Again, drugs of abuse testing, we're trying to determine past or current use of an illegal drug or a drug used for outside of prescribed purposes. And then therapeutic monitoring, we're looking at keeping a drug within a therapeutic range to maximize efficacy and minimize toxicity of a drug. So when selecting the best specimen for tox testing, the most important consideration is understanding when and by which route the drug was exposed. So generally speaking, when we talk about oral ingestion of a toxicant, Within that first hour, the best specimen is the GI tract, so nasogastric lavage. Not all of the specimen or sample has been absorbed into the blood, and so you can pull out a sample and then test it for whatever you may suspect or for a panel of different drugs or toxic agents. After that first hour, up to several hours, you would use the blood because we know the drug has been absorbed into the blood. We saw that in the tox lecture in biochemistry where that patient that had ingested over 2 times the daily dose of acetaminophen, we measured the acetaminophen levels after 4 hours in the serum in that patient. So that is the specimen of choice after a couple of hours. And then after 4 hours, this drug or any substance is now being metabolized and removed from the body. So the urine is the best route, and that's what's used for detection. And that's also what's used for a urinary drug screen that we're going to talk about shortly. And so, of course, you wouldn't collect a gastric specimen if the toxin was injected. Of course, you have to, if you don't know, you would probably take the blood sample, but after investigating the patient physically, if maybe there's something in the stomach, or you might want to take a specimen from there too. It depends. But these are the general specimens of choice. So for drugs of abuse testing, as I mentioned, urine is the specimen of choice, and we're just looking for current or past exposure or use of a drug, and we're looking for the drug above a certain cutoff level. And so, yes or no, is the drug there? If it's above the cutoff level, yes. If it's below, then no. Here are the analytes that are detected in a standard urinary drug screen with their cutoff levels. So you have amphetamine, cocaine, PCP, ecstasy. Does anyone know why there are 2 opioid levels on the standard urinary drug screen?
Is it for heroin?
Not for heroin.
Is
Yes.
it because it metabolizes into like
Another opioid? No, but it does, but you're correct. No, it's because now everything is so, I like to say, cute and trendy, and poppy seeds are now and everything. So they put poppy seeds in salad dressing and muffins, and to me, it's just a cute way to like try to make something cute and make people want to buy it. But I mean, I like food, but I don't like cute food. So you guys know I like food. So they added this 300 nanogram level for people that were testing positive for opioids, but that had a high dietary consumption of poppy seeds, because now it's being added to a lot of dishes. Does that make sense? Yes, no? Okay. Any questions about the standard urinary drug screen or urine drug screen? All right. So for drugs of abuse testing, when somebody reports to urgent care or emergency department, they're gonna do point of care testing. They may make them do a urine drug test, or they may actually a urine drug screen, or they may actually draw their blood. It depends on how the patient presents and how cooperative they are. And that is for like determining whether or not somebody that reports what their level of intoxication is. But for employment and legal purposes, there is two levels of testing. So you have an initial screening test and then a separate confirmatory test to ensure that the patient sample actually contains the suspected drug of abuse. We're going to talk about that a little bit more later on. With the forensic or employment type testing, chain of custody is very important because you want to make sure you can document that the sample has not been mishandled or tampered with during the entire process from collection to it being put on the analyzer and being tested. And sometimes that is a long process. When I was stationed in Germany and we collected blood for forensic testing, we had a series of lock boxes, and we even had to put it in a lock box and ship it to the States where the Dover lab in Delaware would test the sample. So it's a very contained process to ensure that the sample has been unadulterated. Here are some commonly tested drugs of abuse by drug class, mechanism of action, and examples, and their toxidrome. So for these clinical presentations, we're looking at cognitive state, pupil, and respiratory rate, and then whether or not these drugs are included on the standard UDS. So half of these drugs are included on a standard UDS, urine drug screen. The remaining are included either on an extended urinary drug screen or a specialized test that laboratories have, since some of them cannot be detected with the standard urinary drug screen. So we have opiates. Opiates are natural drugs, and opioids are natural and synthetic compounds, and we know their mechanism of action. They present, of course, when we think about opioids, and when I think about opioids, I think immediately about the respiratory rate, decreased respiratory rate. They also present with pinpoint pupils, and in severe cases, coma and death can occur if that respiratory rate falls too low. So if we look at the toxidrome clinical presentation characteristics, there is some overlap, but there are only a few that present with dilated pupils. Opioids only present with are the only ones that present with pinpoint pupils. But if we take another example, bath salts, we know that's a CNS stimulant manufactured. It presents with dilated pupils, and it causes severe agitation and paranoia. And it is not found on the standard urinary drug screen and requires specialized testing. So understanding the toxidrome clinical presentation characteristics of these patients are very important, because if you were to see a clinical scenario, for example, right? Okay, good. Well, that's still clear. Well, good. So if you were to see a clinical scenario, you should be able to identify what the likely toxidrome or what the likely suspected drug of abuse is. So if we take the first example, 25-year-old male found unresponsive vitals, respiratory rate 6, blood pressure 88/54, heart rate 52, has pinpoint pupils and improves after naloxone. What's naloxone? Opioid antagonist. So it's going to kick that opioid off of the mu receptor. And so because of these characteristics and the clinical presentation, you would suspect opioid overdose, and this is found on the standard UDS. Some of them are not. For example, we take this third example, 35-year-old female is lethargic and slow to respond. Her pupils are normal, vitals are stable, UDS is negative, but her husband reports that she takes a sleeping aid. what is the most likely toxidrome? And why is the drug screen negative? So her husband said that she took a sleeping aid. These are not found on a standard UDS, nor are some muscle relaxants, which can also be used as sleeping aids. So that is why the UDS was negative. Are there any questions about that? No, all right. So now we're gonna shift gears to talk about therapeutic monitoring, the characteristics, why we do it, and some examples of how they impact general principles of pharmacology. So, we monitor drugs therapeutically in order to keep the blood concentration of a drug within a therapeutic range that has been tested in probably thousands to hundreds of thousands of patients and is shown to be efficacious and have reduced toxic effects. And so phenytoin is talked about a lot throughout this lecture. We saw that clinical scenario in the beginning where that patient presented with the toxidrome or signature fingerprint characteristics of phenytoin toxicity, that ataxia, confusion, nystagmus, which is the oscillation of the eyes. That patient, once you see those clinical characteristics or clinical presentations in the patient, that dose was adjusted in the patient and returned to a blood concentration level that was therapeutic, minimizing toxicity. Why do we use TDM? Well, we use it for drugs that have a narrow safety profile that we talked about, phenytoin. There's some other examples we're going to talk about. We also use it because the condition that the patient has, the disease or whatever disorder or condition, there's no clinical endpoint in mind. So we don't suspect the disease to fully resolve itself. So we use the blood concentration of a drug that is known to treat whatever the condition is based on the drug. We use that as a surrogate marker. We also use it to distinguish the toxicity of a disease versus the symptoms of a disease. For example, bipolar disorder, we use lithium to treat it. There is some overlapping symptoms with the drug and the disease. Agitation and irritability are one of them, or two of them. And so if we see a patient that presents with agitation and irritability that has bipolar disorder, we need to first confirm based on other characteristics if that patient has relapsed or if they have a toxic dose in their blood. So that's where we need to understand and know that the clinical toxic effects of a drug. So for lithium toxicity, in addition to agitation and irritability, you may see GI upset and tremors. So if you see those two additional characteristics in the patient, then you would be able to distinguish out the effects of the disease versus the effects of the toxicity of the drug. Does that make sense? So the freshman said I wasn't allowed to say, does that make sense? But I think I said it for you guys because they said it wasn't a real question. But yeah, anyway. So I'm glad you guys let me say it. Good. I see some shaking head nodding, so good. So we also use TDM to just make sure that the patient is taking the drug in the dosing regimen that was prescribed, because drugs with narrow therapeutic indices, those drugs will have, if you double up, you could risk significant toxicity because, of course, there's no direct correlation with the dosing and what is found in the blood. So that's another reason why we use therapeutic drug monitoring. And then drugs that have to be monitored in this way have variable pharmacokinetic properties. So any or all of the pharmacokinetic pillars, which are what? Absorption, metabolism, man, yeah. ADME, yeah, something. Y'all know this, say something. So any of those characteristics can be altered by the intrinsic characteristics of the drug, and we're going to talk about some examples of that. Also, drugs that are monitored in this way, they're variable sometimes within a patient and between patients. So the blood concentration level based on a specific dose might be variable from patient to patient or within a patient depending on certain characteristics of the patient. So because of all of these indications, this is why we use therapeutic drug monitoring. And of course, if we use this, then we definitely have to have a clinical assay that's able to detect or tell us an accurate blood level, blood concentration of a drug. So we talked about the disease not having a clinical endpoint, but TDM drugs don't have an endpoint as well, meaning that there is no marker in the body that can tell us that the drug is working. Like if we use the example about the serum example about the APAP toxicity that we talked about in biochemistry last semester, when that APAP level was drawn after 4 hours, we saw that it was significantly reduced in the blood based on the amount that was absorbed. And so you continue to check that level after maybe 4-hour intervals to determine when the drug is removed. So for TDM drugs, you can't really tell what they're doing because there's no like markers in the body, like there's no liver enzymes that can tell you, oh, the liver's still good, the liver's not having any significant toxic effects. So we use TDM and that blood concentration level becomes the surrogate marker for what we want to know about the drug. I mentioned the narrow safety profile, and we also need to understand the correlation between the drug's dose and the toxicity. So knowing the characteristics when a patient presents with the efficacious dose, the blood concentration level is within that therapeutic range, versus the toxic characteristic, the toxidrome that we talked about. So these drugs, we have to know the differences, and there has to be some differences in order for us to effectively use therapeutic drug monitoring. And then, as I mentioned, there's a variable dose-response relationship with these drugs, meaning that any principle of pharmacokinetics might be altered, or even pharmacodynamics. There may be supersensitivity of the receptor or a paradoxical effect of the drug on a certain receptor, and we'll talk about that a little bit later. So when we talk about the unpredictable dose-response relationship, or when a drug has one dose ends up producing variable blood concentrations in the same or different patients, that is why it's important that we monitor these drugs. So digoxin is another drug that is a TDM drug. It is used for heart failure. It is mostly eliminated unchanged by the kidneys, but about 20% is metabolized by what enzyme? 3A4. 384. I don't know if I told you guys. I think I did. If you guess 384, you're probably going to be right for for drugs. But 384. So most of the drug is eliminated unchanged by GFR, and so if a patient is dehydrated, they are going to have less body water, more concentrated digoxin levels. If they have kidney dysfunction, they are going to hold on to that digoxin, and then it's going to potentially be toxic and can cause arrhythmias in a patient. So for TDM drugs, the specimen of choice is serum or plasma. We're going to talk about why in a couple of slides. And so when we measure the blood concentration of a drug, regardless of where the drug acts, if it's tissue specific, we're measuring the concentration in the blood. That becomes a surrogate marker. And so based on that concentration, we know if the drug is within that sweet spot, so to speak. And so I'm not going to go over these in a whole bunch of detail because you guys already know the general characteristics of pharmacokinetics. And so TDM drugs can have any of these steps altered, absorption is altered, or any one of these can be altered in a way that makes the drug likely to produce toxic effects or subtherapeutic effects in a patient, and it's based on the intrinsic characteristics of the drug itself. So drug absorption, we know the properties that affect drug absorption: blood flow, GI motility, the properties of the drug itself, whether or not it's lipophilic, charged, uncharged, everything that we talked about. So in the last block of biochemistry. So if we take T4, levothyroxine, that drug is not to be given with food because that can significantly alter absorption of the drug. And so you need to know this information and of course educate your patients, because if they're not taking the drug as indicated, it's going to cause variable amounts in the blood, likely in this case subtherapeutic levels. And so it's not a matter of the dosing so much. In this case, it's a matter of following the instructions based on the properties of the drug. So for distribution, we know that drugs travel through the blood bound to blood proteins, albumin. But for the clinical assays, we are measuring total drug concentration in the blood. So that's free and bound. And of course, what portion of the drug is the active portion? The unbound, the free, correct. So regardless of how much is free versus bound, we're looking at the total amount. It's kind of expensive and time consuming for clinical labs to separate that out. They do in certain cases, but they've done a number of studies looking at free and bound drug together and determined the blood concentration levels that subtend to the drug being efficacious, even with it portion of it being bound. So if we have two scenarios of phenytoin, a therapeutic scenario and a toxic scenario. Scenario 2 is the toxic levels, looking at the blood concentration. So if you are assessing a patient, of course, you wouldn't know what portion is bound or free. You just see the total concentration, 20 milligrams in each. So what would you suspect to be different in this case in terms of the patient in general? Yes, so absolutely. The patient has hypoalbuminemia, and since phenytoin is highly protein bound, if there's less protein to bind to, the drug is going to be, a lot more of it will be free. And in this case, double the amount is free, and this amount is toxic in this patient, and this patient will present with one or more of those toxidrome characteristics: ataxia, confusion, eye oscillation, and so you would have to couple the concentration with how the patient presents. So knowing both pieces of that information will let you know if the patient is in toxic versus efficacious or sub-therapeutic levels of the drug. So if the patient is having multiple seizures, then they probably are in a sub-therapeutic blood. They probably have a sub-therapeutic concentration of the blood, in the blood. And so, speaking of therapeutic, you guys know what therapeutic range is. It's that sweet spot where the drug works at its best, where the efficacy of the drug is its best and the toxicity is minimal. And so we want a drug to be above the minimum effective concentration and below the maximum toxic concentration, and that gives us our therapeutic range. Anything outside of that, as we see, this is subtherapeutic, therapeutic, and toxic range. And you can even see at high doses within the within therapeutic range, some patients are already starting to experience toxicity, which is common. And so here is the therapeutic range of an orally administered drug, time concentration curve, time versus concentration in the blood. So of course, orally administered, it has to be absorbed. Once it enters the blood, it's above that minimum effective concentration. And how well it acts within the therapeutic range is the drug's intensity. So that deals with the pharmacodynamics of a drug, how many drug molecules are binding to the receptor to elicit whatever effect the drug has on the receptor. So during a dosing cycle for our patients, we need to know the minimum effective concentration and the maximum toxic concentration of a drug. And of course, we're just trying to find the therapeutic range. So when we are measuring drugs for therapeutic drug monitoring, we are trying to detect these levels. So almost all drugs that are therapeutically monitored, they are measured after the drug has reached steady state. And what does that mean? 5 half-lives? Yes, 5 half-lives, absolutely. 4 to 5, yep, 4 to 5. Does Major Hart teach 4.5? Does she teach 4.5? Huh? Okay, because we not an argument, but when we were fighting about that because we learned something different. So, but 4 to 5 is fine. And so that is basically equal. Steady state occurs when the amount of drug entering the blood is equal to the amount of drug leaving the blood. There's that equilibrium. So for TDM drugs, we measure, or we take the blood draw at the trough after the drug has reached steady state. That's how typically all drugs are measured. So we're able to determine the minimum effective concentration of the drug. For metabolism and elimination, we've already talked about some of the enzymes that metabolize the drugs. And so, of course, these enzymes are primarily found in the liver. If there's liver dysfunction, of course, that's going to affect blood flow, that's going to affect the enzyme activity. So you need to know that type of information in your patient in order to adjust the dose accordingly. And that is just a general principle, not necessarily for TDM drugs, but for drugs in general. If your patient has liver issues or kidney issues. So elimination is additive, and it includes the removal of drug from all the organ systems. And so if a patient has chronic kidney disease and they're taking digoxin, you know that clearance is going to be an issue. So you're going to need to adjust the dose accordingly, because if you don't, then the patient will likely experience toxic effects of digoxin because it will not be cleared from the body as readily. Are there any questions? Okay, good. All right. So, of course, wrong tubes, handling of the specimen, your results will be skewed. So I mentioned the collection tube. It is a red top. That red top tube has no additives, no anticoagulants. And so you're gonna measure the TDM drugs after steady state in the trough to get that minimum effective concentration of the drug. And what are the benefits? So you know the benefits to maximize efficacy, minimize toxicity. I also mentioned earlier, some drugs have paradoxical effects in some patients. So if we know how much of the drug is in the blood and we see a paradoxical effect, we know that either this patient is just an anomaly or we might need to adjust the dose, or there may be interactions with this drug with another drug in the body. Also, another important benefit is we talked about disease states, liver issues, kidney issues, but like temporary changes also are important indications for TDM. So in the cases of pregnancy, that affects absorption, that affects total body water, that affects phase 1 enzyme levels. So in cases of pregnancy, you would need to adjust the dose that you give the mother, because it also can affect the baby in utero as well. So we use that for this indication as well in order to ensure safety for both mother and child. Any questions? All right, so here are drugs that are commonly monitored. We have the drug class and examples, their mechanism of action, their toxidrome or the signs of toxicity, and the reason why these drugs fall into this category. As I mentioned, most of them have narrow therapeutic indices. However, some of them are very toxic to the organ systems, and so they need to be monitored to ensure that those toxicities are minimized. So here are some more clinical case studies of different drugs that are monitored. So if we take let's take the second example. 36-year-old with epilepsy reports slurred speech, gait instability, and nystagmus. He has not had recent lab follow-up. What drug class might be responsible and what test should confirm it? So those clinical presentations, I've mentioned them several times, that is hallmark for anticonvulsants phenytoin. And so that would be what you would measure for this patient, the test you would order. Are there any questions about this table at all? All right. So we talked about specimen of choice, red tubes, nothing in the tube, and when to draw after steady state in the trough. Other tubes can cause drug interactions and distort the levels of drug in the blood, which is why we don't use these tubes. So light blue top tubes, that citrate takes up about 10% of the tube. It's lining the tube. So when you add the blood, the anticonvulsant drugs in particular will be diluted. So that will give you a false decrease in samples. Some drugs might get stuck in a gel separator tubes, again, giving you a false indication of the amount of drugs in the blood. Gray top tubes are used to measure alcohols. So that fluoride in the tube is specifically there to block glycolysis if our tube gets any contamination with bacteria during the phlebotomy, because bacteria can convert glucose into ethanol in the tube, so that would falsely elevate the amount of ethanol in the tube. But that fluoride blocks an enzyme in the glycolytic pathway that we don't have, that humans don't have, but that bacteria have. So in order to ensure the ethanol levels are actually from the patient itself. And then the green top tubes contain the additive heparin. Heparin activates fat lipase enzymes. So it's gonna break up the triglycerides, and those fatty acids are going to basically kick the drugs off of albumin and bind to the albumin itself. So when fatty acids bind, they kick the drug off, and that gives you a false elevation of the amount of free drug in the blood. So these are why you don't use these tubes to measure TDM, or even for drugs of abuse testing particularly, you would use ethanol, you would use gray tops for DAT testing if you collected a blood sample. The type of clinical assays used are immunochemical and chromatographic. They both are fast, and the immunoassay is more of a screening, and it uses antibody detection. So what happens is, in the sample, you have the drug from the patient sample, and then you have fluorescently labeled drug that is a part of the kit that is used in the immunoassay. So basically, whichever binds to the antibody the most will help you determine how much of the sample is from the patient. So if you have low fluorescence, that means less of the fluorescently tagged drug was able to bind to the antibody, and that means that there were more drugs from the patient sample. So there's an inverse relationship of fluorescently tagged sample versus patient sample. The lower the fluorescent tag, the higher the patient drug in the sample. And then chromatography, you have two types. Well, you have multiple types, but chromatography uses the characteristics of how a compound passes through stationary and mobile phase of an analyzer, and based on those properties, it tells you what the chemical characteristics of the agent and what actually the agent is. So for liquid chromatography, though, that is used for large polar molecules, and it uses a mass to charge ratio to tell you what drug is present in the sample. And then gas chromatography is used for volatile drugs. And so, and how well or how fast these agents pass through these different phases of the analyzer system will tell you what drug is present in the system, and it's very precise too, so it can detect very, very low levels of the drug. I believe pico levels of the drug can be detected using this confirmatory method. So, we're all familiar with this. We donate at least once a year, and this is the test that we know we're gonna get 100 on. This is the probably, least we hope, right? So this test, what you guys need to understand about the DOD testing and just drugs of abuse testing in general is how long the drug stays around in the system. And of course, that's based on specific properties of the drug. So of course, hydrophilic drugs are more likely to be eliminated faster unless they have active metabolites. So benzodiazepines, they're lipophilic, but they also have active metabolites. That's why there's a range. Methadone, it's mostly hydrophilic. And then THC, 30 days. So that's being stored. It might be 60 days for me. You guys know why, because I have way more fat than y'all, right? So understanding the times that the drug can linger in the system is very important, particularly just to understand, but if patients are using drugs for illicit purposes or unintended purposes, they might want to know this as well. So when we are looking at our DOD testing, it's a two-phase approach. We have the urine drug screening test first, and then we have the confirmatory test. So what happens is if a person tests negative for the UDS or the urine drug screening, the initial screening, then that doesn't mean that there's no drug in the sample. It just means it's below the cutoff level. So that patient is good to go. If that person tests positive, then another screen will be rerun. If that is positive again, then we will use that confirmatory testing to confirm the actual levels of that drug in the patient sample. And of course, I talked about the chain of custody being very important in this patient, or for the patient samples. So here, if we look at lab result, here we have the patient identifiers, the laboratory accession number, the reason why the test is being performed, IR, inspection, random, and here are laboratory specific columns, the drugs tested, amphetamines, cocaine, ecstasy, heroin, and THC, and the results. We can see that patient 7 was positive for D-amphetamine at 2,098 nanograms per liter. Patient 9 positive for THC. Patient 11 was untestable. LC is laboratory comment. This could be due to not enough sample tampered with, the broken seal, a number of different variables, even labeling issues. And then patient 12, cocaine, and this patient was high as a kite because, for real, because this LOL, it is above the limit of detection of the analyzer system. So that person got his urine or blood drawn and was high and report like floating. So, yeah. So, are there any questions about what we talked about today? No. All right. Good.